Hello everyone and welcome back. I hope you enjoyed some of the discussion of point-of-care ultrasound of the heart and got a chance to see how that may help you save some lives, be more accurate and rapid with some of your diagnoses. Next up, we're going to talk about how sometimes combining ultrasound of the lungs with your cardiac ultrasound can help you make even more diagnoses more quickly, more accurately, and not spend a lot of time spinning your wheels waiting around on other tests like portable chest x-rays and BNP tests and things like that really probably the literature would say are not as accurate as heart and lung ultrasound are anyway. Let's jump right in. We're going to start with a few cases that may help illustrate where we're going to go with all this. So first case, again, as usual, real cases from my life or the lives of my colleagues. First case, a charge nurse grabs you. There's an elderly patient who, quote unquote, needs to be intubated right away. Roll into the room. Patient's in obvious respiratory distress. Looks like they could go into cardiac arrest any moment. Cyanotic, hypoxic, tachycardic. The look of utter fear in their eyes. You're pulling out your intubation materials when you decide you're going to take a quick look with ultrasound and see how that might help you. Our next case is a little bit older man who comes in with shortness of breath. All these people can't talk that much because they're short of breath. This person has a history of COPD and CHF. They've got diminished breath sounds. You hear crackles. Blood pressure's a little on the lower side, so you're trying to debate, sounds like CHF, but should I do nitroglycerin and diurese them or what? What should I do? Well, we decide to do bedside ultrasound, and it may help us out. The next case is middle-aged female, acutely short of breath, who's a smoker and has some quote-unquote heart disease. History is again limited. They're in obvious respiratory distress. You don't hear a lot of lung sounds. So far, they've been getting some beta-2 agonists and not having a lot of response, so you decide to go ahead and take a look and see what you can discern from lung ultrasound and probably adding on the heart as well. With lung ultrasound, here's what we're going to talk about. There's really only 4 findings that we need to concern ourselves with. Now, there's different patterns of these findings in the clinical scenario, certainly very important in interpreting and making decisions around these findings, but there's really only 4 big findings: pneumothorax, pleural effusion, pulmonary edema, and pneumonia. And we'll talk about what those look like, the patterns, the distribution, and how to clinically incorporate that stuff. So first off, a little bit about how to do it and some of the background. There's really good evidence and even society guidelines now that recommend ultrasound of the chest and the lungs as first line for pulmonary disease. The accuracy over portable chest x-ray or even upright PA lateral chest x-ray is much better for things like pneumothorax, pleural effusion, pulmonary edema, pneumonia, and fortunately for this, you can pretty much use any transducer that you have. And I will tell you, as someone who never used to do lung ultrasound and then started incorporating gradually and ever more frequently lung ultrasound into the practice, you really realize how terrible these portable chest x-rays that we're always ordering are and how they really don't give you much information at all. A little bit about how to do the exam. Like I said, you can pretty much use any transducer you want. For adult patients, a lot of the time pairing my lung ultrasound with a cardiac ultrasound, so I often have the cardiac transducer or the phased array transducer in my hand, so I'll usually just use that. I will flip it over to a lung or a pulmonary setting because the pulmonary setting does help things like B lines show up better on ultrasound. Stick the probe indicator towards the patient's head in different spots. So the way I like to do this, like I said, I usually have the cardiac probe in my hand, so I will just start in the front. I'll put it in a pulmonary setting, start with the indicator towards their head, kind of roughly in the mid-clavicular line, second intercostal space or so, and just kind of zigzag, lawnmower my way down their lung, trying to cover as much of their lung as possible to look for findings that are going to help me. Then when I come out to the side, I like to start down low and find the diaphragm first so I know where I am, and then do the same thing, just kind of zigzag my way up the side of their chest, all the way. You really got to get yourself into their axilla. If you're not feeling nasty, sweaty armpit sweat, then you haven't gotten high enough. Same thing on the back. I like to start low first, find the diaphragm, and then work my way up. And you got to work your way in between the scapula a little bit. If the patient is able, you can have them hug themselves to pull the scapula out of your way. But I will also say there are a lot of patients who are maybe too acutely ill or too short of breath that I don't even do the posterior views. I just rely on the anterior and lateral views that I can get at the bedside without moving a sick, critically ill patient around a whole lot. So the whole goal is just use whatever probe you have, put it in a lung setting, and then cover as much of the lung as you can, look for the findings, and then whatever the findings you see, incorporate that info clinically. Now the thing about lung is, when lung is normal, there's really not a whole lot to see. So here's what normal lung is going to look like. It's very important when you're examining the lung to make sure that you're seeing a few important landmarks. The ribs, which we've kind of cut off to the side here, the ribs are going to cause shadows, and we want to see the interface of the visceral and parietal pleura where we'll see lung sliding. So that pleural sliding and rib shadows, we need to look for those in every view of the lungs that we're going to do to assure ourselves that we haven't angled the probe off into some soft tissue and that we're actually looking at lungs. Now, another thing about lungs is normal lungs are filled with air, and when the lungs are filled with air, you can't really see much in the lungs because the air just reflects your ultrasound. What we will see sometimes are artifacts, which are pretty much equidistant from the pleural line. The horizontal lines are called A lines, so A lines are present when you hit a bunch of air. So this is a sign of normal aerated lung, although you could also see this in pneumothorax if there's no sliding up here. We'll talk some more about that. Just a couple more examples of what normal lung is going to look like. So again, you put your probe on the chest, indicator pretty much stays towards the head, and you just follow and track up and down the lungs to cover as much of the lung territory as possible. Very important as you're looking at the lung to make sure you see these landmarks of ribs with shadows and pleural sliding. If you're not seeing these landmarks, then there's a good chance you've angled your probe off into soft tissue and you're not seeing the lung at all. So make sure you see these landmarks to let you know you're looking into the lung itself, and look for the A lines if it's normal. A lines aren't always that visible depending on your imaging and how you get your angle, so they don't have to be there, but look for those, and if you see those, that's a good indicator that you're looking at lung and you're looking at air. Pleural sliding, rib shadows, cover as much lung as you possibly can. When you come down to the side, and sometimes posteriorly, you're going to look for the diaphragm. The diaphragm is an important landmark to make sure you're down low. You're looking for things like pleural effusion or other dependent things. Diaphragm is dense connective tissue, so it's going to look bright white, and it's usually going to be right over top of a solid organ like the liver or the spleen. And in the normal lung, you're not going to see much other than gray above it because we're just hitting air, and we'll see the spine often coming up towards the diaphragm and then stopping at the diaphragm. And that's again not because the spine is gone, but because the spine is no longer visible because it's being blocked by the reflections from air. Let's just point that out a little bit. We'll start again. I like to start on the sides down low, find the diaphragm, and work my way up to the axilla, and then pointing out the findings. The spine should stop at the diaphragm. We'll see some shadows from the spine, usually solid organ underneath the diaphragm because this is feet here, head here. Normal lung, just a bunch of gray. All right, so next up we're going to just take a look at the lungs with the curvilinear transducer. Sometimes in a clinical environment I like this because it just shows me more territory more efficiently. We're still going to start roughly the same place, maybe up a little high. And what we want to do when we're examining the lungs for things like pneumothorax or effusions or consolidations. Midclavicular indicators towards the head. We identify ribs and then pleural sliding. And the way I'll examine the lungs is just kind of slowly work my way down and across the front in kind of a lawnmower fashion, some would call it. And the depth is kind of superficial for these anterior fields. So then I'll do the same thing on this side. Again, start up high, identify rib shadows and sliding, and just examine as much of the lungs anteriorly as possible. And looking for things like B lines or consolidations or anything like that. Then when I want to see the lateral parts of the lungs, I'll increase the depth to like 17, 18, something really deep, and I'm going to come out to your side, so I'm going to pull your arm out. Indicators towards the patient's head, about the mid-axillary line, indicators actually to about 1 o'clock, 1 or 2 o'clock. And what we want to do is find the diaphragm first. So here we can see the spleen, the diaphragm. Pointing out that we'll see the spine down here, but it stops at the diaphragm. And as we look into the chest, we no longer see the spine because the air in the lungs shadows it out. And then to examine the lungs in the lateral views, we'll do the same thing where we lawnmower or zigzag our way, making sure we see sliding and rib shadows all the way up into the axilla. And we can pause every once in a while to make sure we're seeing lung sliding, because it's pretty easy to get fanned up like something like this and just seeing into like soft tissue. We're not even looking in the chest, or backwards too far. We're not even looking in the chest here. We're just looking at soft tissue. So make sure we're seeing sliding. So on the right side, we kind of do the same thing. We identify the diaphragm here above the liver, and I want to point out the spine here and how it stops at the diaphragm. And then same thing. We look for pleural sliding up top, and we examine the lung by fanning or sliding anterior to posterior, making sure we see sliding. There was a singular B line that can happen anywhere. All the way up into the axilla. That's the lung exam.